Good morning, everybody, or afternoon, depending on where you are. I just want to thank you for attending today. I know we're in extraordinary times, and I just am very grateful that everybody is taking a little bit of time today to come really hear from Kelly. I'm here just to provide a little context, but to really hear from Kelly, who's got an opportunity to share with you about virtual care coordination and how you can help really strengthen that relationship with patients, not only for regenerative medicine, but really for your whole practice. So let's go into this. I'd like to just give you a little background on myself and on Kelly. Brandon Cusick, Chief Operating Officer for Axiom Regenerative Therapies. We founded Axiom in conjunction with our ASC partners, who are ortho and pain physicians. This would have been 5+ years ago. To dive into what regenerative medicine would mean for their practices, because they were hearing so much from patients that this was an option they wanted to entertain. And we'll talk about the patient becoming a consumer of their own healthcare. So we really put a great scientific team on this to explore what it meant to provide regenerative medicine to patients in the right way. I work with all our Axiom Network partners. We developed this. A lot of my background and training was in clinical research and public health at Harvard University and Children's Hospital Boston, and then as well as University of Kansas, where I reside in Kansas City. I've done some medical mission work in my past. We continue to do that, and then I've got 2 young boys here that we're now on house arrest with, it seems like, and I am both a competitive tennis player and a user of regenerative medicine myself and amongst my colleagues. So I'd like to introduce Kelly. Kelly, if you could just give a little background on yourself for everyone.
Hi, everybody. I'm Kelly Johnson. I do virtual care coordination right now as my current role. I feel very blessed to have it. I've been in healthcare for over 20 years right now, and that's feeling a little scary, but because it's dating myself. But throughout that experience, I started in insulin pump therapy on pediatrics for type 1 diabetics. And throughout my career, I noticed I had an aptitude, or I leaned in towards wanting to help educate patients to improve their quality of life and how they move forward in life. And so I've landed in regenerative medicine about 5 years ago after playing around in surgery centers and developing protocols for outpatient spine, outpatient total joint reconstruction, things in that context. And naturally, you just segued into regenerative care because it's so fascinating, it's so impactful, and it's just really an incredible thing to be a part of right now. So I'm really fired up about where I'm in this spot in healthcare right now. I feel like I'm one of the few optimists where other people are like, boo, healthcare. And I'm like, what are you talking about? Healthcare is amazing right now. So that's the space I come from. I started this really as I kind of created my own role because I had a physician who was a genius with regenerative medicine, but he was really uncomfortable talking about it to his patients. And frankly, he didn't have time. He saw 6 to 8 patients within an hour, and he just didn't have the time. So I developed this role to do that patient outreach. I'm probably over 700 patients strong now. And I chose to go this direction so I could be a little bit more local, closer to home to raise my twins. So you can imagine what I'm going through right now. So anyways, we'll get started. And Brandon, I'll pass it off to you.
Yeah. So we're going to let Kelly take a majority of this, but before we get going, one of the things I wanted to talk about was really understanding the present opportunity for regenerative medicine. We're a company that is in regenerative medicine, and part of that is because we see the marketplace growing significantly relative to the knee and hip implant market. We know that as deductibles increase over time, patients are exploring a lot more options than they used to be able to. And so cash pay, which is where regenerative medicine is today, becomes part of the conversation, and actually a fairly significant part of the conversation, in addition to being educated about the biologics themselves. We know that when you're dealing with chronic pain and you're dealing with different sorts of diagnoses for these patients, we know there's limited clinical options to treat that pain. And eventually, the patients are getting a little bit tired of coming back and perhaps seeking the same sort of hyaluronic acids or visco supplementations and are looking to avoid surgery perhaps. But in doing so, they're really becoming a consumer of their own healthcare. The internet has truly created, on both good and bad, an opportunity for people to seek out the resources and education that they're looking for. And they go out there and they're seeing major athletes getting regenerative therapies. They're seeing people go overseas when they really need to think about that. There's opportunities for them to find a good physician who might be right in their backyard and be able to get educated and have the opportunity to get the right resources applied in real time with their current provider or a provider who they may know. So when we look at the opportunity, there's subsequent challenges. Even in regenerative medicine, which is often called the Wild West of medicine right now, we see inconsistency in patient treatment plans. And Kelly will talk about what that means as she works with her providers to structure those patient treatment plans and be able to support the physician on being able to develop and explain that treatment plan to physicians. We know with unregulated cost, there is no set marker or target on a particular cost. So both from a physician and clinic standpoint, as administrators and physicians, you're thinking, how much should I be buying these products for versus how much should I be selling these products for? And it's more of a business decision than anything for the practice as you look at those types of things. But there really is no regulation guiding that or reimbursement that a clinic might be used to. When we look at clinical protocols, there's certainly a lack of clinical protocols as it applies to, you get a particular diagnosis, you have certain contraindications for certain therapies. You just want to know or have guidance to say, am I doing right by my patients? And part of that we'll talk about is the data collection aspect of your practice and making sure that you're able to collect the outcome data that you are looking for and get an idea of really how to create this protocol or treatment plan for a patient, and then how you can surround yourself with those who are able to educate and inform the patient and set those expectations right out the gate. And then naturally, we are seeing very few serious adverse events due to improper stem cell or regenerative medicine use. But where you do see it, it becomes a real focus of both the FDA and the regulatory bodies. So certainly when you're choosing providers to work with, regenerative medicine providers to work with, this is where you start to look at, are we doing this right? And part of what we focus on with Axiom is really in the ortho and pain space, and work with providers who are using imaging guidance and who are able to go through the appropriate training protocols to learn how to administer these types of things right in line with the FDA. So we know now that the practice of medicine is also the business of medicine, and some of that can be consumer driven. So when we go and think about the patients, why are these patients choosing regenerative medicine? We believe the shift into value-based care is somewhat driven by the fact that the patient is now being a consumer of their own healthcare. Their pain perhaps has become unbearable. They are looking for other alternative interventions. Some want to delay surgery or avoid surgery altogether, and there's certainly no commitments to say you can avoid surgery, but in many cases there are alternatives, and regenerative medicine is one of those. If they've exhausted all their other options and they've gone down the pathway, and we're seeing a reduction in opioid use, but the pain still exists, what can a patient do, and what kind of expectations then can they have if they go out of pocket to pay for a regenerative procedure? And then we just know that amongst tennis groups, golf groups, veterans, running groups, that word of mouth results are being passed from their peers, and sometimes they're using language that may not describe the procedure correctly. And this is where a virtual care coordinator like Kelly, someone educated in this field, can really have the opportunity to clear the air and cut through a lot of the noise that's out there to help a patient put the right words and the right understanding of what regenerative medicine is into their mind, so they can make an informed decision. And so in some cases, we see regenerative patients who have gone elsewhere who are looking for a follow-up, meaning they may have gone to another provider in the area, whether that provider was a appropriate provider is something that is often seen. You have somebody gone, they were pitched a certain thing at a seminar, and then they paid several $1,000s to have something done, and it didn't work in the way that they wanted to. Now they're falling back and trying to find something that may work for them. So certainly as providers and clinicians, we want to make sure that we're providing an opportunity for patients to engage with an appropriate provider, do the right thing, and represent regenerative medicine appropriately to these patients. And then naturally building that long-term relationship for treatment of their pain is really where regenerative medicine fits into the algorithm of the entire pain experience and the treatment for it. So it may not replace some of the traditional therapies that we described or even surgery itself, but it should come into the algorithm a little bit earlier. And that's where a virtual care coordinator can help inform the patient of where they are currently today in that pain algorithm and be able to offer regenerative medicine as a result. So just to pick up on this, here's just to give you a preview. As you can read here, Kelly's going to walk through a few of the effective ways to leverage care coordination. Some people may use a care coordinator. You may reallocate an MA or a mid-level in your practice to be able to do this for you. Some people have hired them on their own, but we've also seen heavy utilization of a virtual care coordinator, which is somebody outside of your office who has a very specific body of knowledge. And that's where Kelly really comes in. So we're going to look at a couple things here, five sections that we're going to focus on. We're going to look at existing patients because in a lot of cases we've talked with providers who say, I want new patients. I want new patients to my door. And certainly that is something that we can do. But the focus on existing patients and speaking to them, you've got a body of people who are looking for something like regenerative medicine to fill the gap if they're dealing with some sort of chronic pain. And so focusing on those existing patients is something not only to market to, but in addition to have follow-up conversations for. Identifying a patient care coordinator, this is where she'll give you some of the characteristics and traits where the communication style and the ability for this person to act as that extension of your practice is really critical, and you really want to feel that relationship. So Kelly will talk about ways that she spends time in the physician's office with them, learning about how their flow works and how everything goes in that clinic, so that she truly feels, so that the patient doesn't lose a step when they leave the clinic from a consult and speak to Kelly. The patient journey becomes also very important here. Their own experience going through regenerative medicine or dealing with their pain and trying to go from consult to making that decision for treatment. There's a lot of steps that go in between there, and we'll talk about those different touch points that a care coordinator will need to have. Operational workflow is something typically established right up front, and she'll show you an example of what that workflow looks like and give you some examples of how she's worked with both clinicians and worked with patients to make this a smooth workflow that works with the clinic and works with the clinic staff and works with the patients. And then naturally, as you go, you can learn and adapt. So in a lot of cases, Kelly has formed very long-term relationships across several years with physicians who have come to rely on her to be able to speak with patients about this challenging subject that is regenerative medicine. And so that we have the ability for these patients to feel like, okay, the clinician, I had an opportunity to speak with him. I know he's a busy guy or gal and needs to move on to their next patients, but Kelly has been very informative. I feel like I've got all the information I need to make a decision. And that decision may take the same week, or it may take a few months for that patient to come around. And the virtual care coordinator is there every step of the way to keep track of those folks. You know, it's really, when we talk about new patients versus existing patients, a new patient would be a lead, somebody who's out there in your market or even outside of your market who comes across you or is seeking a procedure like this. And what we find is that in a lot of cases, it's more expensive to identify, educate, and drive a new patient to the practice than it is to convert an existing one. We like to believe that once you really look at your current patient database and your workflow throughout the day, are there opportunities to have a conversation about regenerative medicine, which means you need to understand certain patient profiles about what those patients look like, what the commonalities are across a potential regenerative candidate. Once you get that language and it becomes a part of your vernacular or part of your mid-levels vernacular, it actually becomes a very easy way to introduce the idea of regenerative medicine, even if it doesn't mean to talk about the financial aspects. And that's where Kelly will really come in a lot of cases. She will be the one to cover the financial aspects of it. So in most cases, she will be aware of both a unilateral and a bilateral cost of all the different procedure types that you offer. And that allows her to take on the burden of that aspect of the conversation, as well as build on the clinical conversation that you had with the patient, outlining expectations. Typically, existing patients are the low-hanging fruit in your practice. You've built a relationship with these folks. They trust you, and certainly as knowing that you're a regenerative medicine provider actually puts you in a unique category of, we'll call it innovative providers in the area who are offering something like this. So as a result, we know that when you do transition from existing to new patients, these newer patients are a little more costly to acquire. This requires marketing budget, informing patients that you do offer this type of service. And generally, those new patients need about 8 to 10 touch points before making a decision. And with touch point, typical touch point that you go through is they'll fill out a form requesting information. They may schedule for a consult, coming in to see the doctor, speaking with somebody who knows about regenerative medicine, receiving the brochures or email content that they need, and then sometimes that can last over a period of months because there's a financial aspect of this, where folks over a period of a few weeks or months will actually need to be able to understand that, hey, if this is a $900 PRP versus a $4,000 bone marrow procedure, they need to know what kind of offerings they have from a financial standpoint. They may need some kind of care credit in order to get through this. And so Kelly works very closely with her practices to make sure that folks know, the patients know that if a provider does offer any form of credit or offer any sort of terms for the procedure, she's able to share that with patients in order to motivate them to come and seek out a procedure. So even if, informing a patient that, you offer regenerative medicine, in a lot of cases, that individual may be following a traditional path to deal with their pain, but they know somebody else who might benefit from your services. So that word of mouth aspect allows them to then pass on the message that you do offer something like this. Just to address the new patient side of things, we know that social media and email marketing are really some of the most cost-effective and authentic communication platforms to reach both new and existing patients. I just wondered if you had any additional points on that focus on existing patients that are already within the practice that have developed that trust and relationship with the physician, maybe perhaps how you work with those folks.
Yeah, I think whether you're doing aesthetics or whether you're doing orthopedics, there's such an opportunity with current patients. So for example, if you're in aesthetics or the med spas place, and you have patients that are in their 60s and 70s coming in for Botox, and they're starting to age out of that procedure, let's just say, maybe it's a good time to adopt or do in addition, like microneedling with PRP and kind of doing an upregulation of elasticin and collagen and those type of things. Same being said for orthopedics. If you have a patient who's doing a lot of hyaluronic acid injections, they're not getting the desired effect out of that, and it's just not working anymore, or steroid injections. This is a great injection. Is it an inhibitor for arthritis? Is it stem cells? So those are the opportunities when you have that existing group to be planting little seeds. It doesn't have to be a long conversation, but just get your patient thinking about what's next. I always think in aesthetics, my mom is this great example. My poor family, they're always our patient examples because we've all done regenerative medicine and we all have these experiences of aging. So my mom went in for a consult with a plastic surgeon I work with and trained with, and he told her she wouldn't be happy with Botox, that she needed a facelift. And she was really not prepared for that conversation. She wanted some Botox, she wanted to look younger quickly, and the idea of spending $600 or $700, $1,000 versus a significant amount more for a facelift was just kind of out of her realm of thinking at that point. Now, she still hasn't done it, but I'm telling you, he planted a seed because she's not doing Botox and she keeps thinking, why not? So when we talk about and this is the same for stem cells, it's the same for when you take somebody to a more expensive type of procedure or therapy. And so they're going to marinate on that for a little bit. So I do touch them frequently in the beginning. So a lot of times it could be that a physician I work with had a consult and they notified me of the consult. I called the patient and said, hey, according to the doctor, you guys talked about this. This is what he's recommending for you. Do you have any questions? And they may not, or they may, but those first touch points, they might be either very long or very short. But I've noticed if I touch them 3 to 4 times after a consult and then wait it out 3 months or so and then touch it again, they kind of come to it when they're ready. So sometimes you just give them a reminder. It's really gentle. But yeah, so I think existing patients are like the mother lode, and friends and family. It helps you build your experience and all that good stuff. So leveraging care coordination, and this could be a patient educator. You can call this, I'm a virtual care coordinator, which makes things easier right now. But however you call this person, it's your patient advocate or your science advocate. And this is a person that's going to increase the conversion to your therapies. And the reason they're going to be able to do this is because the practitioner, the PA, the nurse, the esthetician doesn't have unlimited amount of time. And so to go over all of the questions, Brandon might have touched on this and I probably missed it, but I can spend, when we talk about regenerative science, my first call might be fairly quick, but if a patient calls me back or if I left a message and they call back, those phone calls will range anywhere to 35 to 45 minutes. And part of it is there's so much word of mouth. There's so much misinformation, amazing information, and anecdotal information. So we go over fact from fiction. What's the difference between PRFM and PRP? What's the difference between PRP and stem cells? And that type of stuff. So we go through all of that. What's cord blood? So we kind of go through those differences. So having somebody who's able to touch that patient, really listen to what they're trying to accomplish and answer any questions that are relevant to that. You know, having a me in-house could be probably, it's going to be about $35,000 a year or more, depending on that employee and what all their responsibilities are, and if they, go on a commission program or anything in that context. So, I'm really blessed because I work between, I probably work with a dozen different practices at this point, and on any given day, there's 6 that are super active. So, I have the benefit if somebody's slow, that I work with another practice and help them develop and work with their patients and what have you. So doing a virtual position allows you to not have the out-of-pocket that you might have with their in-house. We kind of talked about bandwidth and having the time. So if each one of my calls and I touch a patient 6 times is an average of 30 minutes, you can imagine, and then they decide to do this in 3 months, how frustrating it would be in the office for you guys, because it's a slow drip. So you want to continue to drip it, and then the cup fills up. So it's just an added convenience and function that'll help the practice move really seamlessly into your next steps. And being well trained really helps you manage all of that. It really helps them in their touches and what you need to be successful. And clinical expertise, although you are the clinicians and the providers of this care, you just don't have time to go through all this. So my role is to be sure that I'm representing your clinical desire as accurately as possible. And we'll get a little bit more into that in a minute in the next slide, Brandon. So how do you begin to do this? Probably the best thing, if you're using a virtual care coordinator like me, it's really easy because all you do is send over demographics and a phone number and what the treatment plan is, and then the patient outreach begins from there. So we establish a workflow in the beginning, kind of who's doing what and when. So it's Susie in the front desk will send me demographics. I then talk to so-and-so who talks to so-and-so, and we kind of work out that workflow in advance. And we do implementation meetings to do that. I require a robust amount of information when I start with a practice because I want to be sure that I'm painting the picture exactly as you would. So pricing and protocols pre and post are really important because the patient wants to know what to expect. And we want to be sure I'm not saying, hey, the patient needs to DC ibuprofen 1 week before and 3 weeks post procedure. And if you all are saying patient needs to DC ibuprofen a month before and 1 month post, we're not on the same team. So it's really important that we collaborate, that all of these little things are put together on who's going to be saying what and are they the same and consistent. And that could be for topical creams you apply afterwards. I mean, it touches so many things in the pre and post treatment plan. So navigating the patient journey, this is kind of where I'm most passionate. And I think everything I've learned, I started focusing on the science when I came to this 5 years ago. And I was so overwhelmed and intimidated by the science that it almost couldn't stick. It was so much at once to go into stem cells, orthobiologics, donor versus a 361 compliant. So all of these things really overwhelmed me in the beginning, almost making it hard to learn. But the patients really taught me, and then I backed into the science. So I listened to the patient and I backed into the science. I'm like, well, why do they feel that way? And then I went and looked it up. So the patient journey is really important. And working in clinic really helped me be able to do this virtually even better. So a patient doesn't want to be pressured or sold, but they can fall out of candidacy. It doesn't mean that what the doctor told them 2 years ago is going to be relevant today. So if the patient has no cartilage in their knee, stem cells they're not magic wands. They can't create something out of nothing. There has to be something to scaffold. Same with elasticity and collagen. I mean, what is the breaking point for microneedling? At what point do you go, well, it might give you a little less hyperpigmentation, but when do you really look at aggressive next steps? So they don't want to be pressured, but I also sort of encourage them like, hey, look, you're stage 3 OA. We don't want to pressure you. We'll treat you. You can have a total knee replacement. We're going to treat you traditionally regardless. But if you want to come to the science, you might want to think about closing that gap before it's too late. So encouraging, just having somebody, and it helps for the physician not to have the pressure to be doing that, because really their emphasis is on their science, their treatment protocol, and their clinical practice. They're not trying to get the patient to spend more money. And ultimately, it's not about the money. It just happens to be a factor that slows down these procedures. So my whole goal is to try to speed those up and do it in a very accurate, kind, and intelligent, educative way. So keeping that conversation going and saying, hey, I know you're coming back in for a steroid injection. Have you thought more about doing something that might last longer? So touch points, touch is really an important component. So in the patient journey, part of we've touched on education, we've touched on a number of things that are really important, but really understanding what the experience is like for them when they walk in the door to when they walk out and what they're going to have a month later is so important to them. And probably my number one questions are, what can I expect? So getting into the workflow, a patient, you kind of start off. So what happens? The patient comes into clinic, they have a consult, and they're given some treatment options. And that could be, all over the board. You can do an HA injection, we can do a steroid, or you can start thinking about regenerative medicine. So doctor comes up with a diagnosis, a plan. A patient has stage 3 OA. We want to either do A2M with stem cells, or a patient's going to consider coming in for a TKR. So then that gets sent to me, the demographics, and I reach out to the patient. I explain that treatment plan, Basically, it's like, hi, Dr. Carlson told me you're thinking about doing microneedling. Do you understand the benefits of that? Did he go over it with you? Then they'll say, yeah, but am I going to be really red? What will this happen? Can I go in the sun? Am I allowed to, use my stem cell serums? All of these questions that might come up. So we go over the questions, answer their questions. If they decide to move forward at that point, I coordinate with the scheduler, and then the scheduler coordinates with me when they have a date, so I can arrange follow-up times. And I do those intermittently. So typically, my personal preference is because after 2 to 3 days of some procedures, I think that patients have a moment of going, oh my gosh, what did I do? Or they have this moment of, this isn't right, or this is amazing. And I like to capture that moment. That moment's really important. And not only to assure them that, yeah, this is normal. Yes, your skin is going to be red. Yes, your knee is going to be sore. Or, hey, you know what? We might want to, I haven't heard that before. We might want to have you come in and doc, we'll take a look at it. So it helps us identify how they did. And it also tells you what to expect and what's normal. So it's part of your training, how they do that first few days post procedure. And then I touch base at 30 days, again at 90, again at 120, and then at 1 year. So those are kind of, and then I like to remind them because they forget. If they got 50% pain improvement, they don't feel like it's good enough. So now as the year goes on and their regenerative therapies are progressing incrementally throughout 6 to 9 months, and they're having some subtle variances, they're not really, they forget how far they've come. So it's nice to have somebody like me who reminds them, like, God, you said you wanted to garden. Look at you. You gardened for 4 hours yesterday. That's amazing. So reminding the patient that they succeeded is another big function of what I do. Or, letting them know that 20% isn't a bad result. So just kind of going through expectations, and you're not always going to get a win, but if you're honest and forthright, usually you have really high patient satisfaction.
Just a summary of some things discussed. Do you have an example or two of some of the ways that you've worked with a clinic or one of the clinics that you're working with right now, and perhaps some of the ways how you do touch a patient multiple times over and over again, say it's for PRP or say it's for A2M, something that might give folks the opportunity to kind of grasp the real world implications of things that we've discussed?
Absolutely. I have it's almost difficult when you get me started on patient experiences and conversations regarding that because I get excited. But an example would be a facility I work with in Amarillo. They are continuing to see patients. In fact, right now I'm quite busy with them because they know they can't go into the hospital for total joint reconstruction. However, the orthopedist is able in that state to do regenerative medicine in his clinic. I think in 2 weeks he'll be able to. So he's asked me to stack the calendar as much as I can. So an example would be we've gone back to their old patients. So he hasn't been able to see a lot of new patients in the last couple of months, but he went back to legacy patients. We started an outreach at just seeing how people are doing 1 to 2 years post-treatment if they've already had an orthobiologic, and asking, just flat out asking if they'd like another. And how did the amnion do in your knee? And do you feel like it's time to come on back? Would you like us to schedule? This is such a good time to heal while everything is so quiet. So we can, what's interesting is I can help build their business even while they're not able to be at their physical location. And that's pretty rewarding. But also I'm excited for the patients who will actually be compliant with their post-treatment protocol. Limiting activity. So, or staying out of the sun, which is a really hard one I notice with aesthetic applications, especially this time of year. So some of those examples is really just, I know there was a slide with a stat that we can convert, up to 50% more patients to these therapies. And I do believe that's true. The difference would be at how you expect 50% to be. So if you were a practice and you sent us 10 patients to care coordinate for, you might get 2 that schedule immediately, 2 that schedule in 3 months, 2 that schedule in 6, 1 that goes a year out, and 1 that doesn't schedule at all. It's going to stagger people are going to treat this like surgery. And so they're going to come to it when they're ready. And it's not always like this, burst out of the gate. It's like I said, it's a trickle effect. So don't be discouraged. Just keep, trickling, filling the cup up, and soon it overflows with patients. And that's some of the advantage of time and relationship building that you guys have put into practice. So, for me, probably the centers I've worked with the longest, which could be, I think I have one for 4 years and one for 4 months. The ones that we have such an established workflow that patients will call me 2 years later, and they'll still have my number because they'll program me in as Kelly with Dr. Parker. And then they'll call me and say, hey, you know what, Kelly, you talked to me about A2M. I'm ready. I have the money and I'm ready. And I find that that's kind of the cool stuff. That's the easy stuff where I look really good and I hadn't touched that patient in a while. So they do come to the science. If they initially showed interest, they're going to come into it at their own time, though. So be mindful of that and don't get discouraged. But most of all, I think that, I build these relationships with patients. I had a patient tell me if I could get him in for a procedure, he would buy the physician a car and he would send me to Mexico on a vacation, which I laughed about until he sent me all the pictures of his vacation home in Playa del Carmen. And it was like, Kelly, pick your dates. My wife will send them to you. You and your family can go down. And I won't take him up on it, but it's an example of impacting life so substantially that, and the doctor didn't take the car either, but we had such a challenge scheduling and we were able to work it out collaboratively. And that the patient was really excited and thrilled, and clearly money wasn't an option or an issue. So these are long relationships, and typically when they have good success doing one procedure, they do come back for a second. So something to keep in mind.
Great,
and with
thanks,
that,
Kelly.
I'll leave it. Yeah,
appreciate it. We certainly want to leave some time for questions for you, but just a couple things to touch on here, going from here, because we're in a stage right now where some practices are continuing to run a robust practices, maybe under limited services, but we have some who are still interested in taking this time to really educate themselves and start growing this aspect, because they know that as things start to pick up and stay-at-home orders start to lift, people are going to start coming back. Cash pay options are a legitimate option for patients, depending on the situation. The pain hasn't left. So what we find is that when you look at the commonalities of these successful regenerative medicine programs, we really identified a few things, having worked with these practices for several years. The physician staff buy-in is really the one we start with. This is where things start from the top, from the physician and the leadership in the practice, all the way down to the front desk person. A good program really runs through the DNA of the practice. And the why regenerative medicine, it may be because your patients are asking for it. It may be because there's other bad actors in the community who are taking advantage of patients, and you go, listen, this is something that falls in my wheelhouse and something I want to be able to offer to my patients and do it correctly, and just make sure I market myself appropriately and be able to do that. And that may be due to you've gotten the education or the training or the understanding on the biologics, and then also on some of the financial aspects of this, that allow you to position your practice in such a way that you're able to stand out from the crowd and sort of lift the noise that a lot of these patients are seeing. This is a cash pay model today, and it's a cash pay treatment model, and not all practices are currently equipped to do that. Those who have med spas or those who have some cash aspect to their practice are positioned a little better to have that cash conversation. But we find that those who aren't typically utilize the virtual care coordinator a little more strongly, because as Kelly's described today, we find that the patient journey can often last weeks or months, in some cases years, as patients are trying to figure out if this is the right thing for them. And then again, converting existing patients to regenerative medicine is actually a fun conversation, something that a lot of physicians really like having that in their tool belt when they start to see the same patient over and over again coming in to get those typical HA injections, and just be able to introduce something more and say, listen, I'd like to be able to provide you with something else. I want to get you in touch with Kelly, who's my regenerative coordinator. She can walk you through a little bit more of the details. It's really a spectacular thing. And so these are some of the pieces. And then, of course, we work with providers across the country today. We're really in the pain and ortho side of things, the MSK and sports medicine, to really have a turnkey business solution. So when we talk about virtual care coordination, obviously Kelly is she's a lead on our team that provides that. Axiom has a proprietary application for data collection that allows you to see patient outcomes and works directly with both patient outcomes and the procedural outcomes, so out documenting and outlining what the procedure is like, and that helps spur the industry forward a little bit and start to really wrap some objective data around this. We have a knowledge center that provides physicians and our partners with the ability to have the most up-to-date literature, the guidance from the FDA, any compliance documents that go along with it, as well as simple marketing documents and things that allow a physician to feel comfortable. Am I marketing this correctly? Am I going to get in hot water? Am I describing these procedures appropriately? And that's what our knowledge center has. And then the print and digital marketing are services that we provide to our partners as well. So when you look at just in general, this is a summary of our program, but really it's more of a summary of how you should look at a regenerative program as a whole. Virtual care coordination runs through the gamut of all of this. But we do, for a monthly management fee, we cover all the essential services. Kelly is an example of someone who helps to identify, qualify, and drive those new and existing patients to these cash pay services to increase your bottom line revenue. And through that, it often reduces the burden of this new service on clinical practice staff. That's probably the number one cited reason for someone really digging in and utilizing virtual care coordination is just to reduce the staff burden and reduce the physician burden, knowing that they have a partner they can hand off who's highly trained in this and who knows how to describe these procedures correctly to help educate and motivate a patient is really a boon to a practice that wants to be serious about regenerative medicine. We have a portfolio of all of the PRP, alpha-2 macroglobulin, bone marrow, adipose procedures that the physician may be interested in and can discuss those further. Most of our providers really want to become that regenerative medicine provider in their community, so we help increase their visibility. That's obviously through some marketing efforts and some local on-the-ground efforts that we can do in conjunction with our partners, as well as increase their reputation through reputation management online, which is where a lot of consumers are turning to every day. And then a lot of things that clinicians got when they were perhaps tied to an educational institution, having nice research folks behind them and good data mines is something that we provide as a company to be able to support our physicians so that they have compliance, up-to-date literature, as well as the ability to analyze and subsequently break out the data so they can understand their patients and the outcomes that they're getting from regenerative treatments. So we are still in the process. We're working more than ever to work with our partners. And if you're interested in speaking with Kelly more, we can set up a time to do that. If you've got, this has been very general as far as trying to apply her practices and her expertise across a variety of practices. But we know you're here today because, you've either started or you're looking to accelerate your regenerative medicine service line. So we hope that this free webinar has been useful for you and gives you something to go back and implement in your practice today. If you're interested in utilizing our services, again, we have a turnkey program that we can work with you on. Please reach out. We'll do a complimentary online reputation scan of your digital footprint, and as well as set up a time to have a call with Kelly and our team to discuss further what care coordination might look like for your practice. So I'm going to open the floor now for some moderated questions, and Rachel, I'll hand it back to you for that. Thank you, everybody, and appreciate it, and stay safe and healthy during this time.
Thank you, Brandon and Kelly. We do have a few questions, so if anyone is still has one on their mind, please feel free to submit it. The first question is, how many patients can one virtual care coordinator talk to in one day?
You know, it really varies if you're able to connect or not. So if you're connecting and each call is 30 minutes, you're going to do, you know, 10 to 12 calls. And you're going to leave a variety of messages in between. So it really just depends on, you know, and then if they're moving forward with scheduling, there's some touches that go from there. But, you know, on a day where people aren't answering their phone, you could easily be at 40 to 50 calls a day. But when you're connecting and you're having those conversations, each call does go 30 minutes to an hour or in between there. So it really just depends on the level of interest. And at that point, then I begin scheduling and coordination afterwards. So there are some touch points after each patient that shows interest.
Thanks. The next question is, I'm slowly building my practice. How many coordinators would I need?
You, at this time, you'd really only need one, and that will help you. And if, you know, God willing, you know, the demand will come, and if you need more, you'll know, because that person will be pulling their hair out. It becomes very transparent if the call volume and touches aren't where you want it to be. But initially, I think one is generally enough for most practices.
Great. The next question is, when you're speaking to my existing patients, would you speak to all of them or hand pick certain ones first?
We would usually come up with a plan if we're going to talk to existing patients. Some of those existing patients might be the ones that have already expressed interest in regenerative medicine. Having some background definitely helps the conversation, so it's not this out of the blue random call. But and then looking at patients that might have had a regenerative therapy or on the spectrum of arthritis or looking to do more aggressive skincare treatments if you're med spa minded, and then tackling it from that direction. But usually we would collaborate on what we wanted the approach to be so that I'm representing the practice the way you'd want.
Thanks.
Yeah, just to add to that, Kelly, we find that with practices, in dealing with the existing patients, we'll start with working with them on an email campaign. So we'll go out to, if you've got a full database of patients who currently see you, one of the ways we work with them is we'll work on an email campaign to create touch points with patients. And out of that usually falls out people who are interested, didn't know about this. So you get a little bit of initial education. We provide website pages and different things that describe the procedures, that describe what a patient may be going through. And through that, doing a little bit of marketing up front allows you to the patient self-select themselves to be able to set up a sort of more in-depth conversation with a care coordinator or directly with the clinic. And then from there, working from there. Kelly will also, we work on site with our clinics, so she'll come in and work with them. And as she sees the flow that a physician has set up or the staff has set up, she can figure out how to work within that and provide some ways that a physician can maybe create those points to introduce regenerative medicine into the conversation, just simply through shadowing for a few days with a doctor in the mid-levels.
Thank you to you both.
That was a great question.
The next question is about talking to patients about cash and the challenges with paying for procedures. How do you guide them or handle those types of situations and conversations?
I think that's an excellent question. All of these are really great questions. It's complicated because you have to be comfortable with it and you need to believe in it. So when we talk about being educated and having experience, sometimes when a practice is starting and they're just getting off in the ground in new procedures, some of the best patients you can treat are friends, family, and your staff. And that's what helps them build, if somebody feels that they had a desirable effect, either in aesthetics or pain management, and they believe in it, it's so much easier to ask for the money. And so I do feel that experience makes that conversation easier, but out of the gates, it's just being very, I can only tell, every person is going to do this differently, and I'll tell you how I do it. And I'm just very respectful to say, and you can almost tell out of the gates when money is a huge concern. And so I try to mitigate that. I said, doctor created this amazing treatment plan for you. The good news is you're a great candidate for it. The bad news is these procedures are not covered by insurance. Do you want to learn more about it? So sometimes I've had to learn how to manage my time so I don't go down this rabbit hole of being excited about stem cells who really somebody has no financial capability of doing that procedure. So I try to identify, are they open to having a cash conversation? A lot of times the practice has already told them, so they're aware it's going to be cash, but I try to be very sensitive. And for those, and if they say, I'm interested, but I don't have it now, I still give them a full synopsis of what to expect, why the physician has chose this protocol, what are the benefits for them, and to come to it when it becomes a more comfortable time. And of course, we'll treat them traditionally as well, through all insurance approved type of scenarios. And so just really being forthright about it. Sometimes people will ask me when I'm training, like, why do you talk about money so quickly? And I think often when you're speaking about science, it can be a bit boring to start with. And people can get overwhelmed quite easily with some of the words I use, and it's why I always follow with a brochure. But so they tend to check out a little bit on the conversation because they're waiting for the price. So I like to get it out of the way in the beginning so they're able to listen to me or stop me from talking if they have absolutely no interest. So I would say don't be afraid and just do it out of the gates. And if you believe in it and they have trust in you, they're going to come, you're going to have a certain percentage that are going to come to it. So just, I guess my best recommendation is to be confident in what you're providing has a significant value to their life.
Yeah, the pricing, to build on that, Kelly, I think that's an excellent insight. The pricing is really interesting because we work with providers who are trying to set their pricing. They would need to understand their market, what their competition is doing, what their patient base is really willing to afford. A case, it's an interesting discussion about the cash pay versus insurance pay because we had a physician that we worked with who goes, listen, I have patients, when I tell them it's $800 for a particular therapy, they balk at it and that it's out of pocket. But it's almost when he says, hey, it's $1,800, he gives a hypothetical. He's like, if this was $1,800 covered by your insurance and you're out of pocket or deductible would be $800 out of that, all of a sudden the patient would be willing to do it. So you have this interesting dynamic where just saying it's cash pay is a big challenge. So Kelly will also communicate with practices if they're going to run a promotion. Again, with cash pay, you have a little more flexibility as far as how you can market and how you can price. So if a practice runs a promotion for a period of time, that's when she, as long as it's relayed to Kelly, she can work with them on that because there's still just the psychology of, am I getting a deal or am I getting the value, I suppose, the value equation in the patient's head is really important to acknowledge. So she can work with them on those pieces as well.
Yeah, I'd like to expand on that just because I think this is a really important component of this and really why this role exists outside of having the time to answer all the questions. It's really the financial component that keeps me employed because it is so challenging to do. I would say that don't underestimate your practice. And I'm going to give a very specific example of a head of a major hospital system in Dallas I work with. He's a head of pain management. Probably I actually created, when I was collecting data for him, I started an Excel worksheet on his patients of how many of them were on disability. And it was a profound amount. And he was an expert on migraines and a key opinion leader on alleviating pain by going up into your top of your cervical spine at C0 to C2 and doing anti-inflammatory treatments to alleviate migraines. And we started it having never done one before. He had never done or used the science, and he was injecting people at the very top of their spine. And most physicians don't even want to do a steroid injection here, much less regenerative medicine. So, you know, we went in very cautiously. And what was amazing to me is we had a really, for such financially challenged people, we had incredible closing rates of people who would borrow money, get credit cards, but he probably had a 35% closing ratio of his candidates that were perfect for this procedure. And considering that most of them were over 50% were on disability, to me, it says that the therapy will sell itself when it's right for the person, and the scenario is just challenging enough. So in this case, these people's lives were so inhibited that the $3,500 he charged, they would make it happen. So, you know, be mindful of your patient population and your pricing, because you'd be surprised how many will make it work if they believe it'll help. And of his 80% of his outcome, 80% of his patients would do it again. In fact, I want to say 20% have done it more than once. So you can change lives, and money will be found. And unfortunately, it's not my job to figure out how they find the money. It's my job to be kind in presenting. We'll pursue every avenue we can until this becomes reachable for you. And just know it's available. We don't want to hold any information back from you.
Thanks. The last question that we have is, what are the medical limitations of a virtual care coordinator?
Rachel, can you repeat that? What are the what?
What are the medical limitations of a care coordinator?
Yeah, that I have not been asked that before, and it's really important. So great question. Thank you for asking that. I obviously cannot talk to them about DCing or starting any medications, vitamins, physical therapy. I can only make general recommendations that are usually outlined in our setup protocol. For example, post bone marrow procedures, I might tell the patient that, you know, they need to do limited motion, no weight bearing type of things, and go through what the physician would normally recommend in physical therapy at what weeks. But my role is really not to give clinical guidance, advice. You have to remain very objective and stick to the physician plan, relay the physician plan, and stay in your lane. If I do notice, and because I've done this quite long and I did work in clinic and in the OR, I do catch things that people might not see because I'm an expert on all of these technologies. I might catch something, and I will not express that to the patient, but if I catch somebody that might disqualify them as a candidate or make them a candidate for a different therapy, I certainly do a reach out to my clinical contact at the facility, whether that be the doctor, PA, or MA, and say, hey, I have a concern about this patient for X, Y, and Z factors. Can we discuss, or would you like me to make a different recommendation to them? So I do, if I catch a flag that might have been missed in clinic, or notice an observation, if somebody tells me they smoke 5 packs a day of cigarettes, they're a drinker, and they're diabetic, is bone marrow really the best idea at 75 years old? I don't know, but I'm going to ask the doctor, like, hey, look, are you aware that this patient is smoking this much? They're not going to discontinue before treatment, things like this nature. So I certainly am not allowed to give any clinical advice regarding prescriptions or treatment plans to the patient, or also guarantee outcomes of any sort. I give generalities that are commonly provided by Cedars-Sinai or some of your top medical institutions, Cleveland Clinic, things of that nature. If I don't know something, I tend to reference the legal verbiage used by the major institutions. I hope that answered that question, and you can expand on that if it didn't.
Thanks, Kelly. I think that sums up all of our questions. So thank you again to our speakers and to everyone who attended today.